Uti+in+children. Introduction. Pediatric UTIs often signal an underlying genitourinary tract abnormality. Can lead to renal scarring with resultant hypertension and renal failure. Difficult to diagnose because symptoms are nonspecific in this age group and testing is often invasive. Pediatric UTIs, epidemiology. Prevalence. Girls, 6.5 to 8%. Boys, 2 to 3%. Uncircumcised boys have a 5 to 20x increase in UTIs versus circumcised boys. Occurs in about 7% of children less than 2 who present with fever without a source. Epidemiology, continued. Incidence of vesicarital reflux, VUR, is 1% in children less than 2 years. 50% of kids less than 1 year with UTI have VUR. Early renal scarring is nearly twice as common in this age group. Incidence of scarring increases with each subsequent UTI. Scarring occurs in 5 to 38% of febrile UTIs. Figure 1 Prevalence of VUR by age. Figure 1 Prevalence of VUR by age. Plotted are the prevalences reported in 54 studies of urinary tract infections in children, references in technical report. Pediatrics 1999, 103, 843 to 852. Figure 2 Relationship between renal scarring and number of urinary tract infections. 16. Pediatrics 1999, 103, 843 to 852. UTI, Classification, upper tract infection. Acute pyelonephritis fever, bacteriuria, systemic symptoms. Lower tract infection. Urethritis. Cystitis. Voiding symptoms, little or no fever, no systemic symptoms. Clinical presentation. Age and gender dependent. 0 to 2 months. Fever. 2 years/0. Fever, greater than 38 C. Irritability. Vomiting and diarrhea. Decrease appetite. Between 1 to 2 years/0 equals crying on urination, foul smelling odor. Females of all ages are more predisposed to UTI due to short urethra. Male urethra as an infant is also short. What is the rationale for why a febrile UTI is bilo until proven otherwise? The kidney is a complex organ as opposed to the bladder as a hollow viscous. Inflammation of the parenchyma of the kidney is responsible for fever. Clinical presentation. 2 years/0, 6 years/0. Systemic symptoms. Fever. Flank or back pain. Urgency, urinary incontinence, dysuria. Suprapubic or abdominal pain. Foul smelling odor. Greater than 6 years/0 in adolescents. Same as above. Urethritis in female infants, in adolescent girls and boys. Part of a diapedermatitis. In adolescent girls and boys. Presenting sign of STD. In preschool and school-age girls. Part of nonspecific vulvovaginitis. Generally environmental. Bubble bath. Nylon panties, also biker shorts, leotards, bathing suits. Poor hygiene, not wiping back to front. Overzealous hygiene. Use of baby powder, perfumes, symptoms of urethritis. Dysuria. Reluctance to void. Perineal discomfort, erythema. May be associated with vaginal irritation and erythema in girls. In older boys, urethral discharge. In adolescent girls associated with PID symptoms. Symptoms are difficult to elicit in younger children secondary to lack of vocabulary. Cystitis of febrile usually frequency in uresis dysuria. Reluctance to void. Pyelonephritis. Usually associated with fever and systemic signs. 2 degrees renal parenchymal inflammation. Older children. Flank pain or abdominal pain. Younger children. Fever, irritability, vomiting, poor feeding. Pyelonephritis, significance. Each infection results in scar formation and reduced renal function. After diabetes mellitus and collagen vascular disease, undetected renal disease and untreated childhood UTI may be responsible for a larger portion of ESRD in adults. A huge need for dialysis and transplantation. It has been the assumption that renal scars are the result of infection. Could it also be that kidneys which are scarred or dysfunctional are at higher risk for infection? Is it an association or causality? Pyelonephritis, significance. Untreated childhood UTI responsible for hypertension, impaired kidney function, complications of pregnancy, causes and course of UTI. Risk factors: age less than 1 year, female, gender uncircumcised males, constipation, voiding dysfunction, improper wiping, genitourinary abnormalities, vesicarital reflux, obstruction, colonization with virulent E. coli. Signs and symptoms: children 2 months to 2 years. Fever, usually unexplained. Vomiting and/or diarrhea. Abdominal pain. Failure to thrive. Malodorous urine. Crying on urination. Signs and symptoms: children greater than 2. Fever. Vomiting and/or diarrhea. Abdominal pain. Malodorous urine. Frequency and/or urgency. Dysuria. New incontinence. Summary: urinary tract infections are a common cause of fever without a source in children less than 2 and can lead to renal scarring, HTN or ESRD. Rapid treatment is essential. Symptoms are nonspecific and thus a high level of suspicion is required. Urine culture is required for diagnosis, and should be obtained by catheterization or SPA when child is ill or infection is suspected. Treatment requires a 7-14-D course of antibiotics. Prophylactic are required after initial treatment. All children less than 2 require 2 imaging studies after initial UTI. References: Committee on Quality Improvement, Subcommittee on Urinary Tract Infection. The diagnosis, treatment, and evaluation of the initial urinary tract infection in febrile infants and young children. Pediatrics 1999, 103 to 843 to 852. Layton, K.L. Diagnosis and Management of Pediatric Urinary Tract Infections. Clinics in Family Practice 2003, 5, 2. Chon D.H., Frank C.L., Shortleff L.M. Pediatric Urinary Tract Infections. Pediatric Clinics of North America 2001, 48, 1441 to 1459. Linda Carr, Shortleff L.M. Evaluation and Management of Pediatric Urinary Tract Infections. Urologic Clinics of North America 1999, 26, 719 to 728. McCullough M., Sharif G. Marks, Rosen's Emergency Medicine, Concepts and Clinical Practice, 5th ed. 2002, 2327 to 2334. Acute Urinary Tract Infections Clinical Effective Committee. Evidence-based clinical practice guideline for patients 6 years of age or less with the first-time acute urinary tract infection. Cincinnati, O. Children's Hospital Medical Center 1999, 1 to 14. Patient groups, options, time horizon, NHS perspective. Long-term antibiotic treatment for preventing recurrent urinary tract infections, UTI, in children. Patient groups: infants of 1 year, girls and boys. Recurrent UTI, no abnormalities. Mild for, grade 1 and 2. Options: long-term low-dose antibiotics, Cochrane review. Trimethoprim, nitrofurantoin, cotrimoxazole. Intermittent treatment of UTIs. Time horizon: 3 years of long-term antibiotics and follow-up to end-stage renal disease. NHS perspective. Model structure for UTI. The evidence effectiveness, existing reviews, variable quality. Meta-analysis, multiple parameter synthesis. Probabilistic trial-based model. Natural history. Epidemiological studies. Pooled trial baselines. Registry studies. Clinical judgment. Quality of life. Published studies. Survey. Costs. Published unit costs and dosage, BNF, ZRU, CIPFA. Antenatal period. The most common cause is physiologic dilation. Metanephrocuring production begins at 8 weeks, even before ureteral canalization is complete. Transient obstruction with hydronephrosis occurs. Embryology. Pathophysiology. Anatomic and functional processes interrupt the flow of urine. There is a rise in ureteral pressure causing stretching and dilation. If pressures continue to rise, leads to decline in renal blood flow and GFR. When significant obstruction is persistent, it affects nephrogenic tissue and results in varying degrees of cystic dysplasia and renal impairment. Grading of severity of hydronephrosis. Most common causes in neonates. Ureteropelvic junction obstruction. Ureterovesical junction obstruction. Posterior urethral valves. Eagle-Barrett syndrome, aka prune belly syndrome. Vesicarital reflux. Ureterocele. Treatment for UPJ, pyeloplasty. Diagnosis. Urine collection. Clean catch acceptable for toilet-trained children, wearing underwear or pull-ups. Ensure cleansing with antiseptic towelette. Catheterized specimen in diapered children. Suprapubic bladder tap in less than 6-month-old child is guaranteed sterile. Frequently, the nursing staff will need to give explicit instructions to parent or patient to actually assist in urine collection. Leukocytesterase has to accumulate in urine. Insufficient accumulation possible in small infants who void frequently. Infants less than 3 months old may not have mature enough immune system to induce leukocytes in urine. Beware neutropenia on CBC. Nitrites. Byproducts of E. coli and other lactose fermenters, glucose digestion. Insufficient accumulation possible in small infants who void frequently. Insufficient accumulation possible in older child during the day and in older patient who has significant frequency. If positive, highly suggestive of UTI, high specificity, microscopy greater than 10 WBC/HbF on spun urine. Bacteria on unspun urine are common unless catheterized specimen. Gram stain is very helpful on spun urine. Standard UA plus gram stain is enhanced UA. Usually reported as 5 to 20 or less than 5. So what to do if you are looking for greater than 10? Urine culture greater than 100,000 Fu per milliliter on any culture. Greater than 10,000 Fu per milliliter on cat specimen. Any bacterial growth on bladder tap, at least 1,000 Fu per milliliter. Sensitivity and specificity of components of the UA. Sensitivity %. Range. Specificity %. Range. Test. Leukocytesterase. Nitrite. Leukocytesterase or nitrite positive. Microscopy, white blood cells. Microscopy, bacteria. Leukocytesterase or nitrite or microscopy positive. 83, 67.94. 53, 15 to 82. 93, 90 to 100. 73, 32 to 100. 81, 16 to 99. 99.8, 99.100. 78, 64 to 92. 98, 90 to 100. 72, 58 to 91. 81, 45 to 98. 83, 11 to 100. 70, 60 to 92. Urine cultures held for 48 hours but usually positive at 24 hours for true UTI. Requires another day for ID of organism. May require another day for sensitivities. If contains skin flora, S. epi, S. aureus or alpha strep, considered contamination secondary to poor specimen collection. Diagnosis. Urinalysis can be obtained by most convenient means if infant is not ill. UTI cannot be diagnosed with UA alone. If suspicious UA, the urine culture must be obtained via SPA or catheter specimen. If UA does not suggest UTI, it is reasonable to follow child clinically. Sensitivity %, range, specificity %, range. Table 1. Sensitivity and specificity of components of the urinalysis, alone and in combination, references in text. Test. Sensitivity %, range. Specificity %, range. Leukocyte esterase. 83, 67 to 94. 78, 64 to 92. Nitrite. 53, 15 to 82. 98, 90 to 100. Leukocyte esterase or nitrite positive. 93, 90 to 100. 72, 58 to 91. Microscopy, WBCs. 73, 32 to 100. 81, 45 to 98. Microscopy, bacteria. 81, 16 to 99. 83, 11 to 100. Leukocyte esterase or nitrite or microscopy positive. 99.8, 99 to 100. 70, 60 to 92. Pediatrics 1999, 103, 843 to 852. Diagnosis: urine culture must be collected via catheter or SPA. UTI cannot be diagnosed from a bag specimen. Diagnosis of UTI requires urine culture. Low strong urine collection, suprapubic aspirate. Gold standard, greater than 99% specificity. Positive culture, any number of G bacilli or greater than 3000 CFU of G plus cocci. Urine collection, tranurethral catheterization. Greater than 105 CFU minus 95% specificity. 104 to 105 CFU infection is likely. 103 to 104 CFU suspicious. Less than 103 CFU infection unlikely. Treatment. Treatment may initiate treatment either orally or parenterally. Admit and use parenteral antibiotics if toxic, dehydrated or unable to take PO. Choices: TMP/SMX, cephalosporin, amoxicillin, check local resistance. Treatment continued. Improvement should be seen in 24 to 48 hours. If not having expected clinical response in 2 days, reculture, consider changing antibiotics and do imaging studies. Complete 7 to 14 day course of antibiotics. 14 days should be given for those that were ill with clinical evidence of pyelonephritis. Prophylaxis. After completion of initial antibiotics, children should be given a prophylactic dose of antibiotics until imaging studies complete. Antibiotics should have high urinary excretion and low serum and fecal levels, thus minimizing the development of resistance. Imaging needs to be performed in all children less than 2 years old with initial UTI. Need to perform at least 2 studies to image the upper and lower urinary tracts. Acute imaging only necessary when appropriate clinical response is not achieved within 2 days. Ultrasound should be done on all infants less than 2 years after their initial UTI. Helps to detect hydronephrosis and ureteral dilation. Has replaced IVP. Need additional study to evaluate VA. is not as sensitive as renal cortical scintigraphy, DMSA, for detecting inflammation and scarring. Voiding cystourethropy, VCUG. Used to identify and grade reflux. Also evaluates the urethra and bladder for abnormalities, important for boys who may have posterior urethral valves and girls with voiding dysfunction. Radionuclidocystography, RNC, can also evaluate reflux, but does not delineate the lower tract anatomy well. Can be used for follow-up exams as has low radiation dose. Renal cortical scintigraphy, DMSA. Very sensitive for evaluating acute inflammation from pyelonephritis as well as renal scarring. Role in clinical management is still unclear. Treatment: no short course therapy for small children. No short course therapy for males. Empiric therapy is directed at organisms and adjusted for age. Choose narrowest spectrum allowable considering host factors. Adjust therapy when sensitivity is available. Short course is not indicated for pyelonephritis, but a recent study suggests it is acceptable in cystitis in children. Archdis Childhood 2002 August 87, 2, 118–123. 4 Antibiotics indications. Any person of any age who appears clinically toxic or who has neutropenia. Infants less than 1 mo until bacteremia, sepsis, and meningitis ruled out. Children unable to tolerate oral antibiotics. Immunocompromised patients. Multiple studies show no benefit to outcome for children treated parenterally versus orally. Archpediatradol Medicine 2001 February 155–135–9. The addition of ceftriaxone to oral therapy does not improve outcome in febrile children with urinary tract infections. J. Mother, 2001, June 13–3, 277–80. Comparative study of cefixime alone versus intramuscular ceftriaxone followed by cefixime in the treatment of urinary tract infections in children. Antibiotic choice: neonates. Ampicillin plus a second antibiotic, usually gentamicin or cefotaxime, to cover for Jeeves, Listeria, as well as gram-negative organisms. S. aureus and S. epi. Can cause hematogenous pyelonephritis, in children instrumented, ET tube, central lines, etc. Vancomycin may be indicated for toxic patients or those unresponsive to initial therapy. Cefixime, Ciprax, oral is as effective as parenteral ceftriaxone. Spiroxime, Vanton. Bad tasting. 10 mg/kg/day. Fluoroquinolones are expensive and off-label in Betty. Rationale is to cover for fecal coliforms, which are usual culprits, need to be cognizant of local organisms. There is literature that supports the idea that Bactrim may be facing increasing levels of resistance in UT organisms. Fluoroquinolones may soon be approved for children less than 12 but are more expensive than most cephalosporins. J. Mother, 2001 June, 13–3, 277–80. Related articles, links. Comparative study of cefixime alone versus intramuscular ceftriaxone followed by cefixime in the treatment of urinary tract infections in children. Gok F, Dutsova A, Baskin E, Iozin S, Bispazen, B. Bacterial virulence. Bacterial spectrum at the first department. Bacterial virulence. Bacterial spectrum at the first department of pediatrics, in 2002 to 2003. N equals 7,850%. E. coli 49. Entericus faecalis 13. Proteus indolneg 10. Klebsiella 7. Pseudomonas spp 7. Enterobacter spp 6. Proteus indolpos 3. Staphylococcus 3. Other 2. Sensitive host age-related factors. Anatomy: short urethra, phimosis and adhesiocellularis prepudii at labia minora, diaper. Colonization. Immunological susceptibility. Mucosal barrier. Inherited/acquired. Immune response. X, IgA deficiency, P1 blood group. Sensitive host anatomical malformations obstruction VA. Meningomyelocele. Prune-Belly syndrome. Stone disease, etc. Age-related incidence of UTI. Management of UTI. Prognosis. UTI controversy number 1, antibiotic prophylaxis. Indications. Grade 1 VA. Frequent UTI recurrences. Problems. PTRXD with antibiotic prophylaxis. Increased infection with Proteus and Enterobacter. Pseudomonas and Candida increased in children with urogenital abnormalities. Drug toxicity and sensitivities. Antimicrobial choices, QHS beta. TMPS MX or nitrofurantoin, GI disturbance. Keflex if less than 3 months. Quinolones in some circumstances. Posterior urethral valves. Abnormal congenital mucosal folds that are thin membranes impeding bladder drainage. Most common obstructive urethral lesion in male newborns found at the distal prostatic urethra. Incidence is approximately 1 in 8,000 males. Approximately 50% have reflux. VCUG is the modality of choice. Radiographic signs of PUF. Distended prostatic urethra. Valve leaflets. Bladder and/or bladder neck hypertrophy. Diverticular. Narrow stream in the penile urethra. Incomplete emptying of the bladder. Treatment of PUF. Transurethral valve ablation, vesicostomy or upper tract diversion. Urethral stricture is a common complication. Fetal intervention carries a high risk with mortality rate of 43%. ESRD, renal insufficiency and chronic renal failure are long-term consequences. 30% of boys with posterior urethral valves whose symptoms present in infancy are at risk for progressive renal insufficiency. PUF, 2 months, MCU. PUF, 2 months. MCU done for suspected PUF. 9 months old child with dribbling of urine and difficulty in passing urine. PUF. MCU done. Uroprophylaxis suggested. Told by another doc, not necessary. Came with high-grade fever after 1 month. UTI. Vesicarital reflux. Retrograde propulsion of urine into the upper urinary tract during bladder contraction. Primary reflux is caused by attenuation of the trigon and the contiguous intravesical ureteral musculature. May be caused by the ectopic insertion of the ureter into the bladder wall resulting in a shorter intravesicular ureter, which acts as an incompetent valve during urination. The ratio of the submucosal tunnel length to the ureteral diameter is the primary factor determining the effectiveness of the normal valve mechanism. It is normally 5:1, and in those with reflux it is 1.4:1. The intramural length increases from ½ centimeter at birth to 1.3 centimeters by 12 years of age. Duplication of the collecting system and ureterosity should also be considered. Some clinical facts about VA. It is genetic. Occurs in about 30% of first-degree relatives. 1/3 of children with a urinary tract infection has reflux on CUG. Primary reflux tends to resolve over time as intravesical segment elongates with growth. Grading of vesicarital reflux. The grading prognosis -5% adult scarring, 5 to 50% screening UTI. Grade I. Grade 2. Grade 3. Prognosis -5% adults. Scarring, 5 to 50%. Screening. UTI. Grade 4. Grade V. Prognosis, resolves spontaneously before adolescence. Kidney is most susceptible to scarring in the first year of life and at the time of first upper tract infection. Scars less frequently develop after the age of 5. VA and scarring lead to hypertension, progressive renal insufficiency and failure. Resolves spontaneously before adolescence. 90% of GR1 reflux, 80% of GR2, 50% of GR3, 10% of GR4. 0 in grade 5 reflux. Treatment, observation, medical treatment of infections. Surgical treatment. Significant hydroveteronephrosis. Indicated if impossible to keep urine sterile and reflux persists. Acute pyelonephritis occurs. Evidence of increasing renal damage. VA. MCU. Care of recurrent UTI. Endoscopic submucosal injection. Endoscopic submucosal injection. Teflon, silicon, collagen, bacterial virulence. Virulence equals factors that enable bacteria to invade the urinary tract. Surface antigens. O. Lipopolysaccharides with endotoxin properties. Induces fever, local inflammation. K. Capsular antigen, prevents phagocytosis. P. fimbriae, bind to glycolipid receptors of the P blood group family. A number of further factors not routinely checked.